I think the key message is, you just heard what I said on the Philadelphia, which is a real revolution. And I'm happy to say that many are following our path in this. But it's not only for the Philadelphia. There are data with immunotherapy even in the Philadelphia negative B lineage. And that will probably large again with blinatumomab, and that again will most likely lead to reduce, not to avoid, to reduce chemotherapy and transplant. There are some data already, some more will come out soon, hopefully, and that's another change. Third point is that we are now have more weapons for the elderly. So I told you in the Philadelphia part, the elderly is no problem. We can go up to 70, 80, 90, we treat it up to 89 and plus, well, even over. It's doable, as long, yes, another message, but this will happen, I'll come to that in a minute. This will happen also in the B-lineage Philadelphia negative, because I'm sure we reduce chemotherapy and transplant, which we're doing in one of our studies, and other people are doing the same. The other message, I think, is TALL started with some, although the data are not bad at all with conventional treatment, there was some movement even in the CAR T cell field, so that's moving. CAR T cells hopefully will move earlier, so they may be further, that's immunotherapy too. That will maybe be another step forward. I think one final point is that we should say that all this is doable, and this is very important, if you have the laboratories, the clinical laboratories working together, and you have the laboratories available. If not, it's all impossible. The Philadelphia story is amazing, but you have to recognize that the given patient has, or does not have, the BCR-ABL at diagnosis. We give, many of us give, a 1 week steroid prephase. So in 1 week, maybe 10 days at the maximum, we should identify the genetic lesion. If we identify, then we can give the TKI, whatever this may be. And this is a pill, it's oral. So that's another enormous advantage. You have to monitor MRD. How many centers can do that? How many countries can do it? If you can do that, blinatumomab is not approved yet for MRD in the Philadelphia part. It is approved in the States, but not in Europe, for instance. So there's an issue. Some countries can give it off-label, but it depends on the rules in each individual country. I hope it'll be approved, because that's going to change completely. But you have to have the drugs. You have to pay for the drugs, you have to have them, or they have to be reimbursed, or it has to be in the health system. So there are practical issues that unfortunately are minimizing the possibility of using these approaches to the vast majority of the world, which would be an enormous advantage, because you could cure elderly patients with a pill, and if you can get blina, that so far is an infusion, but soon it'll be sub-Q. So that's why my plea is that the world becomes a bit more, accessible in terms of technologies and drugs and so on, because we can really impact on patients.